Assalamu alaikum. I am Dr. Asif Mahmoud Rafi. Welcome you all, the viewers, to today's tutorial of nephrology. So today we will discuss about some very common thing and very important thing of nephrology, and that is the glomerular diseases and some associations. So let's get on with the tutorial. At first we need to learn about the structure of the glomerulus. So in the structure of glomerulus, to understand the glomerular diseases, the glomerulonephritis, what is most important? The most important thing is the four things that I want to mention. The number one is, as we can see in the center of the picture, there is a purple cell which is named M, which is the mesangial cell, and there is a rounded structure. There are some rounded structure. There is a slit image of this. So this structure consists of the renal membrane where the exchange occurs. So the renal membrane consists of three parts: the E or the endothelium, the yellow color cells, and the green one, the green layer, is called the glomerular basement membrane, and there is podocyte foot process. So there are, from inward to outward, there are three layers: the endothelium, the glomerular basement membrane, and the podocyte foot process. So these three layers together makes the renal exchange membrane. So this is very important to understand, because these four structures, the mesangial cell, the endothelium, the glomerular basement membrane, and the podocyte foot process, these consists of the main structure of the glomerulus, and the abnormality of this can cause various types of glomerulonephritis. So now we will go towards the classification of glomerular disease. In the classification of glomerular disease, the first thing we need to learn is that the types. There is two type of classification. Number one is according to the histology, or the type of the lesion, whether it is proliferative or it is non-proliferative. The proliferative lesion means that there is structural proliferation present in the glomerulus, and the non-proliferative lesion means there is no structural proliferation. So this is proliferative and non-proliferative. The other classification we will talk about is the etiology. And now come towards the proliferative and non-proliferative classification. The proliferative lesion, as we have discussed in the structure of the glomerulus, that if there is any abnormality or proliferation of the mesangial cells, this is named, number one, mesangial proliferative glomerulonephritis. If there is proliferation of the membrane, as we have discussed, the three parts, the endothelium, glomerular basement membrane, and the podocyte, these will be called the membranoproliferative glomerulonephritis number 2. And if there is an infection and there is an immune reaction, and this causes proliferation of the whole glomerulus, it is called the post-infectious glomerulonephritis. And in systemic lupus erythematosus, except the class 5, the other classes, they also present with this kind of proliferative glomerulonephritis. So other than this, there is non-proliferative glomerulonephritis we need to learn. The non-proliferative glomerulonephritis, there is no cellular proliferation. There is problem mainly in the membrane or in the glomerular other parts. So these are, number one, minimal change disease, number two, membranous nephropathy, number three, focal segmental glomerulosclerosis, and diabetic nephropathy is also a non-proliferative glomerular disease, but it is not a glomerulonephritis. So now we talk about the classification, other classification according to etiology. It is very important to understand the etiology of the glomerular disease. So the primary thing, as we know that the things where we cannot find the etiology, it is called idiopathic, and these are the mainly primary things. So number one, minimal change disease, number two, mesangial proliferative glomerulonephritis, number three, idiopathic membranous nephropathy, number 4, idiopathic focal segmental glomerulosclerosis. These are the idiopathic causes of glomerulonephritis. So these are primary. And in the secondary, there is a primary cause causing this glomerular disease, so it is called secondary. So there is secondary membranous nephropathy, secondary focal segmental glomerulosclerosis due to other cause. Number 3, membranoproliferative glomerulonephritis. Number 4, post-infectious glomerulonephritis, as there is infection is the primary thing and it is causing secondarily the glomerulonephritis. So it is post-infectious glomerulonephritis, is a secondary glomerulonephritis, and SLE causes the renal structure change. So it is a secondary glomerular disease. And also the vasculitis. Various vasculitis causes problem in the glomerulus. So it is a secondary glomerular disease or glomerulonephritis. So now we come towards the clinical presentation of glomerulonephritis. So the glomerulonephritis, how can they present? they present in these 6 formats. So it can be asymptomatic. There is no symptom of this patient. We find in our clinical practice there are many glomerulonephritis that those are completely asymptomatic. So there is no abnormality detected in the patients as symptoms. But if we find that there is problem in the urine routine examination, so it is glomerulonephritis, maybe. And the other thing is macroscopic hematuria. So the patient doesn't have any symptom except he has blood in the urine. So this is called macroscopic hematuria. That can be also a presentation of glomerulonephritis. The other presentation is nephrotic syndrome. We know that what is nephrotic syndrome. Nephrotic syndrome has the criteria. There is proteinuria in adult. We need to learn about the adults. Adult more than 3.5 gram per day. Protein in the urine is nephrotic syndrome criteria. There is hypoalbuminemia, less than 3.5 gram per deciliter. There is edema, there is hypercholesterolemia and lipiduria. So these 5 criteria are the criteria of nephrotic syndrome. We need to memorize that. So this is nephrotic syndrome. So a patient of glomerulonephritis can present with nephrotic syndrome. Now come towards the nephritic syndrome. The nephritic syndrome, there are symptoms of oliguria, hematuria. There is generally the red cell casts and proteinuria, generally not nephrotic range, less than 3 gram per day, and there is edema, hypertension, and the most important thing is the duration. The nephritic syndrome is abruptly onset and it is usually self-limiting. So it is the onset is abrupt. So the nephritic syndrome is of short duration and the nephrotic syndrome is of long duration. And other than this, the glomerulonephritis may present with rapidly progressive glomerulonephritis. So what is this? The rapidly progressive glomerulonephritis is the renal failure over days to weeks. So it is very rapidly progressing renal disease causing this glomerulonephritis, and it can cause renal failure over days to weeks. And there is less than nephrotic range proteinuria, there may be hematuria, blood pressure may be normal, and there may be some features of vasculitis, because some vasculitis can present with rapidly progressive glomerulonephritis or RPGN. Other than these things, these 5 things, the other presentation may be chronic glomerulonephritis, where we can find the patient in chronic kidney disease. There is some common features of chronic kidney disease may present, like anemia, weakness, lethargy. With this, the patient comes to us and we find after the investigations that he has chronic glomerulonephritis, which may present with hypertension, and there is renal impairment, there may be proteinuria, and in ultrasound, that is the most important thing to diagnose the chronic kidney disease. The ultrasound shows shrunken, smooth, small kidneys. So that's all about the clinical presentation of glomerulonephritis. This can present with these 6 phases. So now we come towards the very common thing of difference between nephrotic syndrome and nephritic syndrome. As we have discussed previously, in the nephrotic syndrome, that is insidious onset, and nephritic syndrome, it is abrupt. And in nephrotic syndrome, there is edema, huge edema, because of the proteinuria. There is proteinuria more than 3.5 gram per day. So there is more edema in nephrotic syndrome and less edema in nephritic syndrome. The blood pressure, JVP, may be raised in nephritic syndrome, and the proteinuria is less than the nephrotic syndrome. There may be hematuria in nephritic illness. RBC casts may also be present in the nephritic illness, and serum albumin is low in the nephrotic pattern. So I hope that everyone understands the difference. Now we come towards the different topics of glomerulonephritis. We will discuss it briefly, the topics, because these are sometimes important in the MRCP exam and other exams also. So at first we come towards the minimal change disease. So the minimal change disease, there is minimum change in the histology. So the name signifies the disease. So there is minimal change, and there are some idiopathic causes, mostly idiopathic, but there are sometimes some causes found, and these are very important because the MCQ questions, sometimes it can come. There are drugs like NSAIDs, rifampicin, there are lymphoma can cause this minimal change disease. So it is very important. And the number one thing we need to know, I have marked red, that 25% in adults. So minimal change disease, as we know, it is a disease of the children. So 75% cases may be in the children, but 25% case may come in the adults. So it is very important. So after that, the minimal change disease, the treatment is steroid. Other than this, there is nothing of importance. So the steroid is the main important thing of minimal change disease. So now we come towards the membranous glomerulonephritis. In membranous glomerulonephritis, as we have discussed previously, there would be histological problem in the membrane. So membranous glomerulonephritis, it is a non-proliferative glomerulonephritis, and it is the membranous glomerulonephritis. So there is idiopathic cause, and there is also some other causes that causes secondary glomerulonephritis, secondary membranous glomerulonephritis. So the idiopathic cause left alone. So the other causes may be hepatitis B, hepatitis C, malaria, syphilis, the malignancies, and various drugs can cause this membranous glomerulonephritis, and some autoimmune diseases can cause this membranous glomerulonephritis, like SLE class 5 and rheumatoid arthritis. These are very important because membranous glomerulonephritis may be caused secondarily due to those diseases. So there is a rule of third. Generally, the membranous glomerulonephritis, 1/3 goes to spontaneous remission, 1/3 remain proteinuric, and 1/3 progresses towards the end stage renal failure. So it is very important to know that the prognosis is the rule of thirds. And the management, general management in all the nephrotic syndrome, generally the first line of management is ACE inhibitors, and then we use the corticosteroids. So if the question comes, the management, there is at first ACE inhibitors and then the corticosteroids. So this is membranous glomerulonephritis. And after that, we come towards the focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis, the name tells us that there is focal lesion, and there is segmental lesion, and there is glomerulosclerosis, so sclerosis of the glomerulus. So it can also be idiopathic, but the cause we need to know. The causes are important. The secondary focal segmental glomerulonephritis may be caused by the HIV, Alport syndrome, sickle cells, heroin. So these sometimes come in the question of MRCP exam or other exams. So it is important to know about the other causes of focal segmental glomerulosclerosis. So it has a high recurrence rate in renal transplant. It is also an important question. So we can see in the picture that there is a glomerulus, and we can see the dense part, the sclerosed part in the glomerulus. There is a sclerosed part. So this is focal segmental glomerulosclerosis. Now we come towards the membranoproliferative glomerulonephritis. So before that, minimal change disease, membranous glomerulonephritis, and focal segmental glomerulosclerosis, these three are non-proliferative, and these three present with nephrotic syndrome. And now we come towards the proliferative glomerulonephritis, and these present generally with nephritic syndrome. So the membranoproliferative glomerulonephritis, these are also called mesangiocapillary glomerulonephritis, and there are two types. So what are the types? Number one, it is associated with the hepatitis C infection, and the biopsy shows that there is subendothelial immune deposits or electron dense materials, and which makes the appearance a tram track appearance. So it should be known that the tram track appearance occurs in membranoproliferative glomerulonephritis. So the type 1 we can remember as C, the cryoglobulinemia and hepatitis C as associated with the type 1. And the type 2, we can understand the type 2 as D, the dense deposit disease, 3D. The causes are partial lipodystrophy may be present, so dystrophy D, and factor H deficiency D. So the D signifies the dense deposit disease, the type 2 membranoproliferative glomerulonephritis. So it should be remembered like that. And there is also type 3, which is associated with hepatitis B and C. And the management, mostly we need to know that the steroids are the management. We don't need to understand or memorize the protocols or the guidelines for the glomerulonephritis management, because it is not a speciality. In medicine, we just need to know the management of steroid. Now we come towards the IgA nephropathy. The IgA nephropathy or mesangial proliferative glomerulonephritis, it is the commonest cause of glomerulonephritis, and it sometimes it overlaps with HSP, Henoch-Schönlein purpura, which is also named IgA vasculitis. So when there is a systemic illness involving all the systems, it is called Henoch-Schönlein purpura. So it is named IgA vasculitis because there is deposition of IgA in various areas. In the skin lesions, we can find there is IgA in the skin biopsy. In the kidney biopsy, we can find the IgA in the kidneys. So when it involves all the organs, it is named as IgA vasculitis or Henoch-Schönlein purpura. When it involves the kidney only, it is IgA nephropathy. So this is clear. So we just need to know that what are the associated conditions of IgA nephropathy. IgA vasculitis is one of that, and other diseases in which we can find that IgA deposition, those are alcoholic cirrhosis and celiac disease. We know that in the gut we find the IgA, dermatitis herpetiformis. In the skin we can find the IgA. So it all rounds around the IgA. So these diseases are associated with IgA nephropathy and IgA. So the management is steroid. The prognosis is sometimes it is good, sometimes it is bad. Markers of good prognosis is frank hematuria. We need to know that because it doesn't seem to be a good prognostic factor, but this frank hematuria is a good prognostic factor. So the poor prognostic factors are male gender, proteinuria, and more than 2 gram or nephrotic range proteinuria is more marker of poor prognosis. Hypertension, smoking, these are the other markers of poor prognosis. So there is we can see that there is mesangial cellular proliferation in the slide, that there is mesangial proliferative glomerulonephritis. There is proliferation in the mesangium. So there is an important differentiation between the IgA nephropathy or the mesangial glomerulonephritis and the post-streptococcal glomerulonephritis. The first thing we told that in IgA nephropathy there is mesangial hypercellularity or proliferation. In post-streptococcal glomerulonephritis there is proliferation of both membrane and the mesangium. So this is the first difference, and the second difference is usually the respiratory tract infection happens, and after 2 to 3 days the IgA nephropathy develops. So there is an association. But in post-streptococcal glomerulonephritis, the upper respiratory tract infection occurs, and after 2 weeks or 3 weeks there is renal involvement. So post-streptococcal glomerulonephritis occurs 2 to 3 weeks later after the upper respiratory tract infection. So there is a gap between the infection, respiratory tract infection, and the glomerulonephritis. In IgA nephropathy, the gap is smaller. So that is called, for this previously it was called syn-streptococcal glomerulonephritis, the IgA nephropathy, and the post-streptococcal glomerulonephritis is another thing. So the general presentation is the recurrent episode of macroscopic hematuria in IgA nephropathy. So this is important. So other than this, we need to learn about the rapidly progressive glomerulonephritis, also known as crescentic glomerulonephritis. So what is this? Previously discussed that it has a rapid onset and it can cause renal failure within days to weeks. So what are the glomerulonephritis that can present as rapidly progressive glomerulonephritis? Actually, all the glomerulonephritis can present as rapidly progressive glomerulonephritis except the minimal change disease. So what are those? Mainly the Goodpasture syndrome, ANCA-associated vasculitis, post-infectious glomerulonephritis, mesangial proliferative glomerulonephritis, membranoproliferative glomerulonephritis, SLE. These all can present as rapidly progressive glomerulonephritis. The most important thing is Goodpasture syndrome and ANCA-associated vasculitis. These two are more common as a presentation of rapidly progressive glomerulonephritis. Okay, so that was all about the glomerulonephritis and glomerular diseases, and the presentations, the small questions that may be important for the exam. So I hope you liked the video, and that's all about the glomerular diseases. Thank you all.